so much for coming. Just because people had fear of eating last time, can you all please open your noisy lunches if you've got them with you? They're your noisy, smelly lunches. I encourage you to eat them right now because a few people were too self-conscious to open their lunches last time, which is like the thought of sitting in front of like cold soup is really sad. Oh, so there we go. Tara's already eaten.
For me.
And we have an additional public health message from Tara as well. Just a wee bit of welcome. So my name is Maxine McIntosh. I'm a PhD student at the Alan Turing Institute, which is where you are. I presume you've gathered that by now. So we're the National Institute for AI and Data Science. We work across lots of different domains, health being one. If you have any questions about the health program, then please find anyone from the health program or ask me about how to get involved, how to contribute, and what the health program even is. In addition, this is an event with HealthTech, which is a community that I co-founded a few years ago. And we're a community that looks to get more women, people from diverse backgrounds into health tech. But really, we're just really good at community building and making people feel friendly and welcome. So hopefully you've all been speaking to your neighbours already, because I did bully you on entrance to make sure you spoke to your neighbour. So it was nice to see so many people chatting. So on that basis, we started with a really naff, lowbrow game last time, which we're going to repeat, but move through the lunchbox. So last time we asked to introduce yourself to your neighbour and say if you were a sandwich, what sandwich would you be? And this, we're going to move up now. If you were a Walker's type of flavour, it can be wacky. What sort of flavour would you be? Can you speak to a neighbour and introduce yourself and also have that really intellectual and inspiring conversation with them?
Pack of crisps.
If you were a pack of crisps, what would you be?
Marmite.
Marmite.
I know it's terribly exciting what crisps you could be. Shh, 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 shh. It's like being at school. Shut up! God's sake, everyone be quiet. Stop it. Guys, seriously, it's a crisp question. Kill. Anyway, I'm glad that stimulated Right, guys, come on. It's only crisps. Gosh, I can't wait for the next lunchbox challenge. This is so exciting. Anyway, so whilst you're still finishing your crisp conversations, that was enough ice-breaking for a month, I think. So just to introduce the actual session, we've got Tara Donnelly, who is the Chief Digital Officer of NHS England, open brackets, interim, close brackets. And she is joined by Rachel Neaman, who has a enormously varied background in digital health, working across public, private, and government. And I'm particularly very excited about Rachel because she's a lady who I've heard a huge amount about and I've never actually got to meet, so I'm particularly excited to hear from Rachel. So the format is 25 minutes of a kind of fireside chat between these two individuals, and they're going to talk about their career path, how they end up being where they are, some of the projects they're currently working on, and some of the big themes obviously happening in government, specifically around also NHSX, but also how do we make sure that everyone is digitally included when you're thinking about this from a government perspective. And then we're going to open up for about half an hour, 25 minutes for questions from the floor. So please do prepare lots of interesting, nice questions for Tara and Rachel. Obviously, we are on social media, so please do hashtag OHT19. We'd love to hear your thoughts. And without further ado, I'd love to welcome Tara and Rachel. Can we have a round of applause, please?
Thanks ever so much, Maxine, and it's really lovely to see all of you here today. So I'm Tara Donnelly, and I'm going to kick off. We've done that, haven't we? This is the fireside part. Now, it's going to move in a minute so that we actually look. We actually have the feeling of being by a fireside on this beautiful day.
If it gets too hot, we might be.
Yeah, we'll get the front row to edge back a bit to give us some space. But Rachel, what's your connection with medicine?
So I'm not a medic myself, but medicine, I guess, is really in my blood. My mother was a GP in the city for all of her career, and she now has a GP practice named after her, which is very nice. My uncle was a neonatologist for UCLH and now has a ward. named after him. My grandfather was the Dean of the West London Medical School. His father, my great-grandfather, was Dean of Guy's. His father, before him, was a physician, and so it goes on. So medicine's very much in my background. And I was really brought up with the values of the NHS and the importance of care for all and the importance of treating people as equal and as human beings, I guess. Which is something that has really stuck with me, and perhaps is partly why I've been so interested in inclusion and equality and diversity in that sense.
Great. So, shall I say a little bit about my background at this point?
Yes, I mean, we've known each other for many years now,
Good while.
And we started working together properly when you asked me to join the advisory board of Digital Health London, which was great, and it's been great getting to know you since. I believe you started off as a ward assistant or ward housekeeper.
Yep, that's right.
Many years ago.
I did.
In the NHS, and you're now interim CDO. How did that happen?
Overnight, yeah. No, my ward housekeeping job it remains one of my favourite jobs I've ever done, actually. It was fantastic. It was in my year off. A friend of mine who was a medical student had done 2 years as a cleaner and then finally trusted him to be a ward housekeeper. Which is a brilliant job because you spend the whole day doing things that either patients or their relatives or staff are deeply grateful for, and it's your actual job to just do that. So all day long you get thanked, whether it's helping a blind lady read her menu, or in those days you could even have flowers in hospital, so flower arranging I got quite into as well, or getting someone a pen to write the notes. It was just from the whole day you just felt part of a team and doing something really important and really helpful. So he'd had to do 2 whole summers of being a cleaner before he was trusted with this role. And as soon as they saw he was halfway decent, they said, "Have you got a friend?" So I came straight in. He was a bit miffed, actually. But yeah, did that job for a good year, actually, saving up to go travelling, and absolutely got bitten by the NHS bug, and that's been me really ever since, with massive lack of originality. But I've really enjoyed it the whole way. While I was at university, I ended up working as a domestic supervisor at weekends at the Hammersmith Hospital in my 2nd and 3rd year, and I decided I'd like to give this a go. So I applied for the management training scheme, and I was interviewed by a very smiley ex-trainee and a very dour Scotsman who actually had a moustache that looked like Adolf Hitler, which I was a little bit troubled by.
A little disturbing.
And anyway, in the end, this was the kind of first stage interview, he shook my hand and said if I didn't get on the scheme, he'd like to offer me a job. And the woman said, "Oh, I think you're not allowed to do that." And the arrogance of you thought, well, that won't be necessary. But anyway, when I didn't get on the scheme, I was like, who the hell is that man? Where is he? And I had to scour the country to find him, and he was as good as his word and created a job for me. I mean, it really was quite amazing, actually, because in my final year, I also won a travel scholarship to India for 4 months. So I phoned up this man's PA, and I did my finals, went to Turkey with my mum for 10 days, was home for 1 day, and then went to India for 4 months. I said, would there be any chance of an interview the afternoon of this particular day? He was a very busy man. Anyway, he saw me the afternoon of that day.
That's incredible.
So what a superstar. So he said, you can go on your trip in the full knowledge that when you come back, you've got a job with the NHS. So what a trooper. Brilliant. Took a risk on an arts graduate who didn't have a clue, really. And anyway, that's been me in hospitals, moved on to more kind of clinical management-y jobs. I think my big break really was when I became Director of Operations at the Whittington Hospital, very close to my heart. I was 30, and what was lovely about that was that they had 2 directors of ops, because even from a big general management job, it's quite a jump to the board. So I got my board experience in pretty early. Did that for just over 6 years, and then became Chief Executive of a hospital, the West Middlesex Hospital, which I have to say I thoroughly enjoyed. But then hit my second bump in the road, my first being not getting onto the scheme in the first place, which was that my hospital missed a target and I had to move on very quickly, which was a bit of a surprise to all concerned. And I decided that I had as much career ahead of me as behind me, and I had quite a few options. I didn't necessarily have to go straight into another kind of career job. So I could work for myself for a bit, and I got a number of job offers, not least because all my mates are chief execs. So at one point I was juggling 32, thinking, oh, what do I do next? And the weirdest one of all came from UCLH, who asked me if I would be their medical director. I said, well, I have many things, but I am not a clinician of any variety. And they went, oh, don't worry about that. Don't worry. That whole side of things, that's fine. So I went to spend a day with the medical director to see what and they are like chief execs of their patches. And in fact, one of the bits I ended up running was twice the size of the hospital I had run. So in running the bit of UCLH that has Queen Square and the Eastman and so on, that's a £320 million budget, it's 4,000 staff, it's enormous. So I had a fascinating period at UCLH doing a range of different things, but really settled on an improvement job. And that's really where I started interfacing with digital. So I come from the ops trenches of real life, and I could see the possibilities that digital were, particularly around freeing staff time when done right. So that kind of got me interested. And then I was contacted about the job at the Health Innovation Network, and it felt an enormous leap to move out of a hospital after these 27 years of being in them. What a fabulous period, because if you know about academic health science networks, you're part of the NHS but with none of the bureaucracy, with a small team of people who are there to drive improvement. So the colleagues you work with are just absolutely exceptional. So I spent almost 4 very happy years there, and I was having a perfectly good time until I did get asked just after Christmas would I step into the interim chief digital officer job. And part of the reason that appealed was I've been the lead for digital and AI across the AHSNs, across the 15 of us, for a while. So I've actually sat on this board as a kind of challenging but supportive, hopefully, colleague, kind of going, can we go a bit faster and can we try some harder things? So it feels a total poacher turn gamekeeper moment to be asked to chair it now. I kind of feel like, oh, fair cop, you've got me. Let's give that a go.
Well, I think it's great that you've done that, and I think you will certainly have seen a lot of change in the time that you've been in the NHS, and certainly in terms of digital. And now we have NHS X.
Yes.
So do you want to tell us a bit about
how
that has been created?
So, so the idea about NHS X is that we seem to have a number of people in the digital space, particularly in kind of policy and strategy, as well as delivery, scattered across several organisations, and that it would be a great idea to pull this team of people who work kind of as a virtual team, but closer together. So there's around 80 people in the Department of Health and Social Care on the digital front. There's almost 300 on the NHS England stroke improvement side. The idea is we get these people together and at the same time free up some of the processes that we probably don't need anymore that make things take a bit too long. We could actually achieve a great deal more, and we could support both the marketplace and the NHS more significantly.
I think you're inheriting some of my old team from the Department of Health.
May well do.
You are indeed. So we'll talk about them afterwards. We're very lucky to have them, they're great.
And I should also have mentioned I'm also president of the Health Chief Execs Club,
you are.
Which we imagine that some of the great dignitaries from your past were also members of, because it's been going since 1885. And it started as the Gentlemen Hospital Administrators, because they were all gentlemen, meeting in the hallowed halls of Barts. And in fact, it wasn't until 1980 they let women in, which just feels so remarkably recent. So it's quite ironic I am the current president.
I think it's fantastic you're the current president. I have to say actually that one of the things my grandfather did when he was Dean of West London and ran the medical school there was he really encouraged women to take part, and particularly during the war, because all the men were away fighting. So he was absolutely a great champion of women in the health service. So I think he'd be absolutely delighted that you're president of that wonderfully august group of people. So some of the changes that have happened, I guess, in the health service over the years has been the move towards much more patient empowerment, patient control, if you like. And I guess that's embodied ultimately in things like the NHS app that you are currently delivering. Do you want to tell us a bit about that and the difference that that is going to make?
So the bit of the digital landscape that I look after at NHS England Improvement going into X, that's rather long, isn't it, is called Empower the Person. So it sort of does what it says on the tin. It's the patient, citizen-facing stuff, not the infrastructure or joining up. You know, those other important pieces of work fit under other people's remit. So I have things like the NHS website, which we were just talking earlier, got its record number of hits in January, got 46 million people from the UK looked at it, which is pretty amazing given we're only about 66 across the whole of the UK. So that means 2/3 of people are having a look. And it was another 11 million from outside of the UK, with a big peak in people checking BMI calculators after Christmas. It seemed to make a statistically significant surge to the volume. So the NHS UK website, which is really important, the content is now syndicated through Alexa, talking to more and more people about how we can get validated healthcare information to more people. It's, you might have noticed, it's much more commonly the top search on Google when you're looking for health advice. So that's really important. And a number of other schemes, including widening digital participation, so helping people who might lack the confidence or the resources to make the most of this digital age. But as Rachel says, a lot of focus at the moment on doing something that we've never really tried to do before, which is to give a digital tool to everybody across a country. And in doing that, work with 7,171 GPs. I've come to learn that number quite well because I'm slightly obsessively tracking how many of them are live with the app, and as of yesterday, 52% of them are, which is great. How we can give people a much more accessible route in. So for quite a few years, GPs have ticked a box to say that they're making the summary care record available to people. In fact, only quite geeky people who have gone to quite a lot of lengths have actually looked at it. One of the things we found fascinating with the beta of the app is that everybody's looking at their record immediately. And you can imagine, if you're not unwell, you don't need to make an appointment, but everybody's having a look at that piece of information. And it's really interesting, isn't it, to see where the appetite is. The other thing that's really interesting is how many, because it needed to be made available on Google Play and the App Store on the 31st of December to hit a ministerial commitment. So quite a lot of people have downloaded it and clicked the button for email me when my GP is online. 80,000 people did that. We've done no marketing. We're not going to do any public facing until October, until we're confident that enough people will be able to book appointments. But there's just something really interesting there about appetite. And 60% of people who are using the app have never used any online NHS service before. So we're reaching new groups of people for whom in the past we might have been making it too difficult. And then the final thing I'd say about the app is that it has been tested with all sorts of groups. So people with learning disabilities, with dementia, with low reading ages, it's ultra accessible. So I've had some criticism from people going, oh, it's not very bells and whistlesy. It's a bells and whistles free zone deliberately and proudly. And what we'd like to do is link with lots of other tools in the market and not limit what innovation is out there, but say as the universal offer, let's make this something simple and straightforward. Let's not clutter it up with unnecessary things, but let's help many more people use it. And already we're starting to get some lovely stories. There was a nice one on Twitter the other day where somebody was with their mum in a community setting, and she was asked about her medication history, which is quite complicated, and she couldn't remember most of them, as many of us wouldn't. But she was able to show the app to the clinician who had never heard of it and thought this was the best thing since sliced bread. Somebody else was giving blood and they needed a vaccination date again. So it is that whole, and a piece of work we've done recently with people with long-term conditions who we think will probably be the most enthusiastic users of this because they're interfacing with primary care so much, kept using the expression, putting me back in control.
Yeah.
So that message about actually this is your information, you should have it, you should know your past visits and so on. It's also got an ability to select data preferences and organ donation preferences, and we're seeing quite a lot of people following up on that as well.
I think that is very interesting, and I mean, it's just interesting hearing you talk because NHS Choices, I was at DH at the beginning when we started all of that, the NHS app library. I remember writing all the submissions to the then Health Secretary about whether or not this was a good idea and whether or not we needed to change primary legislation and goodness knows what else. Hearing now about your app. So, I mean, one thing that has often struck me is the slight mysticism that surrounds the health profession and health professionals. So, for example, my mother sadly got Alzheimer's in her early 60s, so she had to leave her surgery, obviously, and when she finally went into a home, the carers were sort of, but she's a doctor. But this is terrible, she's a doctor. How can a doctor be like this? And it was an extraordinary sense that somehow doctors are beyond the normal, things like that don't happen to doctors. Doctors don't get sick, rather than doctors are just normal people. And I think there's also been a tendency in the NHS in certain areas to have quite a paternalistic and hierarchical culture. And I think one thing as a woman that's been in the NHS for all your career, how do you feel that has affected you and your career, if at all? And certainly because recently, a few months ago, we had certain Me Too style stories about bad experiences of women working in the NHS. Has that happened to you?
I found the NHS has been a fantastic place to build a career as a woman. And I think the only time that I've ever asked for special treatment or different treatment was when I became a parent. So having those conversations about how can you work at a senior level but not necessarily be there all the time.
Yes.
And I might have just been lucky, but the people I spoke to who were all male chief execs, and in particular Sir David Sloman was absolutely amazing, as was Sir Robert Naylor, in completely getting it, that this was, and had that not happened, particularly at the Whittington, that my career would have been completely different as a result, because I was able to work 3 days a week in a director level job. So I had the career points to get me onto the next place. And those conversations were remarkably straightforward. And in fact, the one with Robert Naylor, which I was slightly gearing my loins about more than the other one, was astonishing in that what he said to me was that he had 2 fantastic children who he was getting to know as adults because he hadn't really seen them when they were younger. And he wished he had done something like I was doing, which was not the response I was expecting at all. So I have to say that I've been very impressed. And you know, the NHS is over 70% female workforce. If we don't have a bit of creativity, we are completely stuck. But I have found it a really good place to build a career. I've not found that that's been a limitation at all. I would say a second thing, which is that my mum was a big career girl. She was a prison governor, and she was the most senior woman in the prison service when she retired, which when I was growing up I found quite annoying, right? So it's slightly annoying, isn't it? And I remember one day cycling to her whatever prison she was running at the time, and obviously it takes quite a long time to get in because all the locks and all that. So I was stuck in this
probably
lobby.
Just as well, actually.
It probably is, in the grand scheme of things. But I was stuck in this lobby bit for ages while they faff around with the keys. And I noticed it was an old sort of fashioned sort of wooden thing with all the governor grades, because, you know, we think we're hierarchical. So governor 6, And I just, because I was there for ages, noticed there were probably about 25 names. And every single one of them was Mr. apart from my mum at the top. I must have been about 15, and I just thought, oh, that's quite unusual, isn't it? I felt a bit stupid that I hadn't, because I didn't, I thought everybody had a dad who was a pretty rubbish house husband and sort of made terrible food, and a mum who didn't come home till quite late, and I just thought that was life. I just suddenly felt really proud of her, and also a bit stupid that I hadn't noticed that before. But I think it does give you a slight, not entitlement exactly, but a kind of sense of self-confidence that if you're not completely rubbish and you do work quite hard and you do a good job, you probably succeed. So that's probably the ethos that, you know, there's the minor bit of annoyance is kind of compensates for, I think, in just a sort of attitude to life, that why wouldn't you, if you work hard, do all right? And why wouldn't your opinion be worth listening to, and that sort of thing?
Well, if it's your role model that is closest to you and closest to home, then absolutely, you wouldn't question that. And you would consider that you can do everything. So if you can do everything, Tara, what do you see yourself doing in a couple of years' time? Everything.
If you can do everything. No, I don't think I'll go quite that far.
Well, let me narrow that question a bit. What do you think then? What do you see as the greatest contribution that technology will make to health in the next 3 to 5 years?
Wow, the greatest. I suppose I still feel very impatient to catch up with the things that we do in our personal life. I think that the kind of smartphone revolution that has changed every other part of what we've experienced has yet to really come to health. And I think in particular, I still feel, so clinicians working in hospitals are mostly dealing with systems that are non-intuitive. Still, that's a real problem. You know, there isn't the kind of be careful what I say if people are tweeting, but like if Apple was to create an EIHR that was intuitive and worked, that sort of focus on user experience. So people might know that the X in NHSX is about user experience, and that's for clinicians and staff and patients as well. I think there hasn't been remotely the focus on that. And we get it in spades from the products that we use that are innovative. We don't get it so much at work. And I'd like to see that change, because I think enabling our workforce to want to stay, to not burn out, to have a lunch break. I was really serious about the lunch thing. Lunch is evidence-based as a very good intervention, and the highest performing teams have lunch together. So just to remind you, there's a book called Never Eat Lunch Alone. It's worth a read. We could do lunch as a whole separate lunch topic. But these are the things that are going to keep people practicing medicine and practicing nursing and practicing physiotherapy in the longer term. So I would love to crack some of that. And I don't think that's easy. But even just so I wrote a story set in the future where people think that the doctors have got much more compassionate because they hold their hands and they look at them in the eyes when they're telling a story, and it's because voice recognition is happening in the background and they're not slaves to their machine. That's the kind of thing that actually would make the most enormous, because the burden of documentation is getting in the way, and the screen is getting in the way of the interaction. So it would be lovely to see something crack that.
I think that's really interesting. It goes back to your point about no bells and whistles. Because I think in some ways it's easier almost to provide hugely exciting innovation and the bells and whistles than it is to solve the very, very basic problems. And we see this when we talk about inclusion as well. It's easier to focus on high-level tech than it is to actually ensure that everybody across the UK has access to digital technology and knows how to use it. Which is still a huge issue, as you'll know, in the health service as well. And I think that sometimes just getting those basics right, getting the hygiene factors right, not focusing on the really, really extraordinary, interesting, wacky innovations is far more difficult, often, to provide a system that has got a benchmark way of working. That allows clinicians internally as well as patients externally to have the same type of experience and to have the same type of ability to communicate and to have that joined upness that the health service is sadly lacking is absolutely critical. So yes, no, I'm with you on that. Let's forget the bells and whistles until we fix the basics.
And on the question about diversity, did you have some thoughts yourself?
Well, yes. I mean, it's an issue of huge importance to me, and I suppose it's because my experience combines tech with health. Health is female-dominated, as you've said. Tech is totally male-dominated. Only 23% of the STEM workforce are female or identify as female. So, how do we bring that together, and how does technology help us to bring that together? And the layer over that is then, and how do we ensure that everybody who is entitled to use the NHS, the health service, are able to access it as well? If it's free at the point of care, how do we then make sure that people can use digital technology to increase their empowerment? So I think there is something about thinking about the internal workforce of the NHS just as much as the external from an inclusion point of view. If 20% of the UK population still don't have the 5 basic digital skills that allow them to be fully digitally literate, and that is the figure, it's 20% don't. That's 1 in 5 people. If you look around this room, that's quite a few people. How do we ensure that many of those are going to be working in the NHS? So how do we ensure that those people who are working in the NHS, who are faced with technological advances as part of their everyday work, are able to use those, to understand them, and empowered and confident to use them just as much as the people who are seen as the beneficiaries outside. Oh, Maxine.
Do you want to open to questions?
I'm going to interrupt. Yeah, so a huge thanks already, and we're going to now have about half an hour of Q&A from you guys. So does anyone want to start the questions? Very, very good. First person, and very good that you put your hand up because we've got a cat box. There we go, everyone groans. And so when you answer a question, please obviously say who you are and where you're from. There was some confusion last time, not where you're from geographically, but professionally. If you want to add geographically, that's also okay. And then whoever has the next question, which there was a man in that corner, unfortunately, who put his hand up, which means you're going to have to throw it quite far. So first question, over to the...
See, that's a bells and whistles issue, you see? Just use a mic.
So thanks for putting us on today. This is wicked. My name's Kat Divers. I've just launched a website called mypickle.org, and what it aims to do is to help people find support across a whole variety of issues, including health. The way it works is collaborative, so people who've maybe experienced something or have knowledge in a particular area can put forward, have you a support service to be listed or a story of an experience that they've been through. So I've got maybe 2 questions. I don't know if that's allowed. The first is around the NHS long-term plan when it talks about social prescribing. And I was wondering what plans are in place around that, particularly right now my site only lists national services and not local services, for the fact that I can very quickly verify whether a national service is legit. Whereas local services and activities are like really valuable, but how do you make sure or validate that they're not causing any harm to people who may be in a vulnerable position? And then the second question is around the patterns or the correlations between health but other issues that people face in their lives that may be related, like debt and mental health, and what work is being conducted or what resources are out there to better understand that. So.
Shall I kick off,
Yep.
Rachel? So on the first question, yes, it's a really good point. And there are some people doing some great work in this space. So one of the joys of social prescribing is that often some of the greatest community assets are tiny. They're not national charity run. They are run by a couple of people in a Gurdwara and getting the information on the latest is quite tricky. An organisation called Health Unlocked, which are a fantastic SME who run the biggest now peer social network tool. I think they're getting about 5 million interactions a month. And they started with rare disease, so it was a way to contact somebody who had the same rare disease as you, but you might never have met somebody with that disease. But they've been commissioned to do some work on creating digital maps of social prescribing in a number of areas. They started in Dorset, and then we at the Health Innovation Network work with them in Wandsworth and Merton to do exactly that, because we think a digital front door to those tools is really, really important. But I'm not aware of national thinking on that subject. There's obviously been some quite large increase in funding of link workers within the new GP contract, which is really welcome news, because one of the issues about some of the community assets is the people who could benefit most kind of need seeking out and joining to them. So the link worker resource is really, really important. But I'll see if I can find out some more and link with the team. It sits with the personalised medicine group of people who are doing quite a lot on personal health budgets, which is also another way that people could start using digital tools. But I'll investigate for you.
Shall I talk about the second?
Why not?
So on the second, absolutely, I think it's hugely important that you look at people's holistic situations and how that's impacting on their health. And again, through digital, there's been a lot of research done, because very often those people who are less digitally able are also those people with greater long-term health conditions or health problems, who tend to be people who are maybe unemployed or less socially advantaged or in lower socioeconomic groups, and so on and so on. So there is a genuine correlation between, say, digital exclusion and inclusion and social exclusion and inclusion. And health is a huge determinant of that and a huge factor. The Good Things Foundation have done a lot of work on this, on the whole social inclusion thing with a digital slant. So if you're interested in that, I suggest you have a look at what they've done, and if you want any introductions to anybody to follow up, then I'm very happy to do that.
good things are working with us on the digital participation thing as well. The other interesting thing is on the apps library, 4 topics make up 95% of searches and downloads, and mental health is one of them. Diabetes is another, pregnancy and baby, and the other is kind of improving healthy lifestyles. They're the 4 big things that people are looking for tools on.
Perfect. Can we go for the next question? You were first. I'm going to just shirk the responsibility and just hand you the mic. There you go.
Thank you. Can I just add to the answer to the last question? I think there is some kind of requirement for local authorities to maintain a database of community assets. So you might be better looking at local authorities for that than at health. But in Scotland, there is a national database being continually developed by the Alliance Scotland, which is a... Yes, that's right. Okay. So my name's Don Redding. I work for National Voices, which is a coalition of health and care charities. The national kind of digital policy in health finds itself really at the intersection of a lot of different interests, because it needs to serve the government's interest, policy terms, the NHS's interest in efficiency. It explicitly is trying to serve industry's interests in getting market entry and creating partnerships. You've talked about the interests of staff as users, and then there's the interests of service users as users. So, following through the logic of some of your opening remarks, how would you ensure that the users, as in citizens, patients, service users, are the paramount consideration in the way that these innovations are introduced and implemented?
So I think part of it is in the role of having a chief digital officer at all. So the role was created a little bit over 2 years ago to represent the voice of the citizen. And prior to that, there wasn't one. It was at the time that a chief clinical information officer was put in, there was already a CIO, but there was nobody there and they're really representing the service and the staff in the service. But there wasn't an equivalent post that was representing the citizen. So I think creating a role did make a big statement. And there's now the portfolio includes 10 very significant programs, of which one I meant to mention is free Wi-Fi, just from the dot everyone.
That's right.
So that was a commitment made after a recommendation by Martha Lane Fox a couple of years ago, and on the 31st of March we got 95% of primary care and hospital and community and mental health trusts live with Wi-Fi, and some really good news today about fibre, so going much faster, which will be terrific. Good. So I think that in itself, and the establishment of a whole programme of work, including the app, was quite important. But I think it's something we just need to stay live to all the time. And I have an explicit role about being the voice of the consumer in board, in the most senior conversations, to just think about how this will land and how this will help. And as we're thinking about things like the roadmap for the app and what might happen next, we're really keen to not have the NHS build anything if there's a better solution in the marketplace, but also that we do all of it driven by quite intense user-based research about what people are going to find the most valuable. What will make this be a tool that people use very frequently? So we know if we can improve anything around the repeat prescription experience, or being able to, so in Spain, you can get your prescription on your phone. You can give it to any pharmacy with a contactless thing, so a bit like an Oyster card. Or you could send it to an online pharmacy who could deliver it at home and work if that was your preference. We make it a bit harder in the NHS. It's kind of the default is the pharmacy next to your GP practice. So we're kind of constantly thinking and testing with groups of people whether these are the right sort of things to prioritise. But you're right, there are a number of things to have to bear in mind. I feel that the voice of the citizen has never been stronger. I really do. That was part of why I thought this might be quite fun when I was having a lovely time with the guys at the Health Innovation Network, because I really do feel this is quite a moment. I think that's
very encouraging. I mean, my view as somebody who's not part of the NHS and not part of government and not therefore connected formally with the system is to be focusing very much on outcomes. and to be very user-centred. So actually, if we're focusing on outcomes for the patient rather than outcomes that are more helpful to the clinician, and which goes back to your point about being really user-centred, and the X in NHSX, so really following that user need thing and getting data to ensure that the outcomes actually do meet the need is very important. But also working with patient voice groups like yours, so that you get that constant feedback in to improve the service. But I do think, I agree with you, absolutely, Tara, from a consumer point of view, a user of the NHS, it does feel as if it is easier to have that dialogue with the NHS than it was before. I think it is there seems to be less of a kind of them and us than there was maybe 10 years ago.
Brilliant, perfect. Hands everywhere. Gosh, let's do two at the same time. The logistics of this is going to be quite overwhelming. So the lady in the white top with blonde hair was first, and then we're going to go, let's make it difficult. Let's go for the lady with the glasses here. So if you want to ask your questions, throw it to this lady, and then you ask your question, and then we'll take two at the same time.
Okay. Hi, I'm Laura O'Connor. I'm currently working at the Royal Brompton. We're developing a patient-centred app, and like you say, there's a real appetite for patients wanting to self-monitor and use the technology that they already have to learn more about their disease and what affects it on a daily basis. So it's great that the patients are excited about it and that the technology exists. The barriers that I'm finding is that tech is quick, but the NHS is slow. And trying to get clinicians to work as fast as the patients want you to is really hard when you haven't got a lot of money to throw at the situation to help staff embed a new technology, which everyone knows is going to work. So what's your advice to help staff and services who want to adopt tech but can't do it as quickly as maybe the patients want it?
Thank you for that question. And pass it over to this lady here. Good throws all round here.
Hi, my name's Claire Griffin, and I'm from IG Smart. Excuse me. We're a IG, so data governance, compliance, data privacy, cybersecurity consultancy. So this is very much a patient-centric question, and I'm sure something which the NHS are taking very seriously, which is obviously around data privacy. For these very sensitive records that are now going to be accessible. And I was wondering, where the kind of, where are the major challenges in that? And actually, have you had feedback from your users, both staff and patients, where any concerns about that have been voiced as people are becoming more alert and aware to some of the data privacy issues that have been in the news recently?
Mm-hmm. Do you want us to do those two? Yeah, before we move on. I completely identify with your question. There is a fair bit of evidence to say that clinician resistance is the main reason for slow pace of technology. Quite often the clinician resistance is for very good reason. If their experience has been that in the past technology has added to their workload, they're going to feel in a different position. You will probably know what's going on, so I'd really like to sort of find out more. Are people fearful and so on? I have had exactly that experience and found that it depends a little bit on the context, but getting users in the room is fantastic. There was a piece of work that was almost finished when I joined the Health Innovation Network around getting uptake of diabetes insulin pumps in South London. Not a new innovation, 1979 was the first clinical trial, but the UK lags in its use of pumps against every other developed nation hugely. And in a 9-month period, running a big collaborative with people with type 1 doing a lot of the flag waving, that group has achieved phenomenal change that nobody thought would be possible. And it was an issue that everybody felt was slightly out of the scope of their control, but when they got together and could hear it directly from the mouths of patients, they just held the feet to the fire in a really effective way. So if you can break that barrier down and have people looking at it at the same time, it can really help. But I would say getting underneath the fears and concerns is the most important thing. When I was a younger manager, more junior manager, I used to, when I kind of met cynicism, I kind of thought, okay, fine, let's do something else. What I learned was that pretty much, I would say universally in my experience, every cynical person, particularly clinicians, was an idealist who had their heart broken earlier on. So they had had great ideas and nobody had listened to them. And if you can find them and listen to them, they become the strongest advocates by miles, by like county miles. Because it's not that they were the innovative one once and someone shut them down. If you can get that back again, it's extraordinary. And also be obsessive about it. Keep going, keep going, keep going. There will, particularly in large organisations, new committees that you never heard of can come and try and shut you down. Just keep the faith, keep it going. I'm very happy to talk afterwards if there are any specifics, but it's absolutely an issue I recognise. Do you want to say anything?
Yeah, I mean, just on that, I mean, very similar, I totally endorse what you've said, Tara, but, I think it's something that will demonstrate to the clinicians this is going to help them as well. It's going to help them do their job better, to help serve their patients better, and therefore help the outcomes. So it's not a sort of, I'm being asked to do this as an addition to my workload. I'm being asked to do something completely different. Why the hell am I being asked to do this? I'm being asked to do something in a slightly different way, which actually is going to be hugely helpful, not only to me, but to my patient. And who's not going to want to do that? But I think there is some, well, okay, it's interesting if you really are. So I visited a hospital a couple of months ago where they had just put in place a new kind of workflow system. So they were to replace whiteboards and so on. And it was great. And so obviously it saved a huge amount of money. But when it came onto the ward initially, the ward sister and the nursing staff just didn't want to know because it was something new. They had to learn to do something differently. It was changing the process that they had been used to doing for, ad infinitum. But they had to do it, and there's something there about seniority in terms of how you ensure that people do it. Within a week, the sister who had said she was going to leave, she had actually thrown her toys so far out of her pram that she said she was actually going to go, has become, as you said, the greatest advocate, the greatest fanatic for this system, and is now, championing it throughout the entire hospital. So there is something about keeping your nerve and getting people to see the benefits and how relevant that is, not only to the patient, but also to them as a clinician.
And just one additional thing I'd say is that sometimes people are very fearful of being the first to do something. So if you can find somebody who's already done it and share notes, that can be a terrific way to see how they got through the issues and maybe have a peer-to-peer conversation. So Southampton are doing some amazing stuff, sharing with the patients. They've changed their prostate cancer pathways significantly. They've had huge support for prostate charities. Everybody thinks it's way better, but it feels very brave. Nobody else is managing patients in that way. So there just might be people that you could link into who are doing similar work who could have a good conversation. And then the question about privacy, yes, it has come up, but it's come up both ways. So so there are a number of issues that people have in using the app, and the most common complaint is the way that appointments are named. And we have uncovered that there are 80,000 ways to name a flipping GP appointment, right? How annoying is that? And some of them are really illogical because they've been designed for the practice to know. So one classic I was looking at on Tuesday last week was like FF diabetes nurse WWS, right? I don't even know what that means. I can guess the face-to-face maybe, but... Yes. So the most common complaint is, I don't really understand. So we're trying to get all the practices but this will take a while. So for a while, the names are going to be a little bit zany. So that's the first thing that we get. And then the second one is people being disappointed at the amount on the summary care record. It's not a lot. Yeah, summary care record is pretty summary. It's kind of demographics, immunisations, and basic appointment history. So people would want, the big message we're getting is people would like the lot. They'd like their full primary care record, and ideally they'd like us to work up secondary care as well. So it's interesting that we're getting more pull. And I recently was in Australia where they've taken a really different approach. Yeah, they've kind of imposed My Health Record on people, and they've had a very high opt-out rate, whereas it feels like we are kind of being pulled by our public, and we're actually not keeping up with appetite, whereas maybe in Australia they kind of went the other way. But privacy concerns, absolutely, making sure that anything in particular that will link to the app in future has had as much review of how it works from a data protection and security point of view as the app itself is important. And that's why we say that everything has to go through what we call the Developer Assessment Questionnaire, the DAX, to make sure we've had a very thorough look. It's about 300 questions, and then a team look at the product itself before they can say that should be able to interface.
I'd say absolutely data privacy, data protection, absolutely crucial, particularly for health. I think one thing that's interesting is how public attitudes to data privacy are changing, and what people accepted a few years ago, or what people didn't accept a few years ago, people are more likely to accept now once they get the convenience of it. I mean, there was a time when nobody wanted to do their banking online because that was terrifying and horribly scary, but now the convenience almost outweighs that. So I think there's a slightly different risk assessment that people have, and maybe it depends what's in your summary care record, but I do think that attitudes are beginning to change. And as long as an awareness of data privacy and actually how data is used, and of course there is a flip side because we hear terrible stories about how data is misused, but I think there is a much greater understanding of the reality of data privacy, and I think a brand like the NHS is not going to misuse our data, is it, Tara?
No, good, Rachel. Crikey. You do remind me, though, of somebody I was talking to recently who was involved with banking going online, with a whole bunch of bank managers saying this is never going to catch on. Nobody's ever going to be using their desktop at the time because phones weren't up to it. So it's just interesting. We can compare notes. It's all a journey.
It is a journey.
Perfect. So we're just going to do, there's a couple more questions. So I know there was the lady with the very colourful outfit that I complimented on coming in next. Barney, do you still have a question? Or you? Okay, I will go to you. Okay, let's go. 2 more questions, quick answers. Yes. Very quick 2 more questions, and then we're going to close. So put your hand up for the next set of 2 questions. Who's first?
Hi there, my name's Lucy Wills. I've got a company called Globefox Health, and we're exploring ways to make patients' ability to contribute their data and to communicate with their GPs as accessible as possible. I'm absolutely delighted at both the efforts that are being made to improve the UX, but also to integrate care more, to make things a lot more holistic. But I'm also getting a lot of feedback, and the research that I'm doing is highlighting that people actually aren't quite sure what data is necessary to contribute, how much detail to give their GPs. They're going to doctors' surgeries and they're being told you can only report 1 issue at a time. And human bodies don't really work that way. But also, we're finding that for a lot of health conditions, especially those that affect women and are comorbid with disabilities, the symptom frameworks are still evolving, and the NHS is catching up, but slowly. So I'd love to know, as somebody who's an innovator from outside of the NHS, partly what's being done to address this, but also how can I help? As a service designer moving into healthcare, what can I do? How do I know where to help?
Perfect, thank you. And then a question to the man over there who's quite tall. Oh, good netball team. You'd be good goal defence.
Thank you very much. My name's Barney Gilbert. I'm from Forward Health, which is a NHS workforce secure messaging platform. My question follows on from this lady's question about implementation. So we are really aligned with what you're both saying on experience. We're trying to build technology that delights every type of health professional and administrative professional across every domain of the NHS. We're doing that quite successfully in trusts, and we're working closely with about 20 trusts to roll that out. Are you thinking at the moment about any particular tactics or strategies or any case studies for companies getting beyond the, let's say, 20 trust stage into 240 or 230 trusts? What's the playbook for scale at implementation to stop a company like ours going overseas as the next step?
The very, very quick response would be AHSNs are doing some great support work in this space. So there are 15 AHSNs covering the country. They have a remit for innovation support that just got strengthened a year ago by the Office for Life Sciences investing in them to help support local innovators. So if you haven't done that yet and you are an innovator, it would be well worth approaching your local AHSN. A number of them run specific digital health accelerators. You'll know about those. And there is also a terrific national programme called the NHS Innovation Accelerator, led by Laura, who's just 2 seats away from me, which is helping those strongest candidates for scale have support from every part of the country to make that next move. It's 5 years ago, I think we didn't have an offering in this space. It was really, really messy. We are getting better, but it's still very tough. NHSX wants to do things that make sure that the market is kept open to and not inadvertently shut out by things, so hence the focus on API development with the app rather than trying to build as a philosophy. So we do want to do more, but we don't want to duplicate what's happening elsewhere. We'd rather augment it and look potentially at the things that where there is a gap. So we're having a session, we're going to be having a session our first 3 months where we do a bit of a listening exercise, and we've already had people pitch from different companies, not for us to support, but just for the NHSX team who don't, for some of us it's meat and drink, but haven't had that experience to kind of hear what the issues that people are facing are, so that we can try from a policy perspective to move some of those things out of the way. But we don't think we should become the place, because otherwise that would be problematic. The people with the relationships to the local NHS are likely to be best at that. I think that answers both. I was trying to answer both.
Okay, I mean, just really quickly, and again, as a non-NHS person, I agree, Barney, I don't think there is enough being done yet to scale. I think that's the next big issue, actually, is in this current, in the way the health service is currently configured. How do you support innovators to scale, watch this space? I mean, I do think it's an area that needs to be, I think it's an area that needs to be looked at, because you can't go around every single trust and every single CEO and say, please come and have a look at my thing. So there's got to be a better way of doing it. I haven't got the answer now, but I think it's something that needs to be looked at. So let's work on the answer, actually.
Perfect. So I know I was going to take another round, but I lied. We don't have enough time. And I'm very conscious to make sure that you get out the door by 2, because I know that the kind of hour is very convenient for lots of people. So a huge thank you to Tara and Rachel. Can we have a round of applause for their contribution? And side point, I feel like if you want to smash it in health tech policy, you need to have a really cool, trendy cropped haircut and shave the back of your neck. So that's one thing that's became blatantly obvious. So just to let you know, this is our second of 4 of these health tech policy sessions. The next one is about data transparency with the ODI, Department of Health, and NHS England. And the one after that is all about openness, and that will be with Hadley Beeman and Kirsty Whitaker from the Turing. Please do just leave if you need to go to a meeting. Don't feel guilty or awkward. And then last thing is that we've got an accessibility fund supported by Everyone. So if for any reason this was financially onerous for you to come to, please just come forward to me. We can give you up to £30 rebate. If it's just for a train, loss of earnings, anything, please just come and ask us for money. We will give it to you. And that's it. Brilliant. Have a lovely rest of the week.